Hello everyone, my name is B.Finley, as most of you know, and this is my capstone project on alarm fatigue and how it affects patient outcomes. Alarm fatigue. The frequent sounding alarms in the intensive care unit lead to alarm fatigue among nurses and their patients. While every patient in the ICU setting must be hooked up to cardiac monitors, they are oftentimes also attached to ventilators, BiPAP/CPAP units, IV fluids, flow track monitors, fall alarms, and other devices that may sound for various reasons. Some reasons could include equipment malfunction, significant change in vital signs, cardiac rhythm changes, change in IV fluid status, or quite possibly the patient has gotten out of bed on their own. These items add much noise to the ICU and become a headache for the patient and the nurse. On this slide here, I included sound at the bottom as an example of what the ICU sounds like. However, it does not work on this computer, so I will pull it up from the clip I got it. This is just a brief example of what it may sound like in the ICU. And I won't make everybody suffer through the whole entire thing, so I think we all get the idea. So, oftentimes these alarms are false, mimicking the little boy who cried wolf. Effects of alarm fatigue. Poor patient outcomes are the most crucial part of it. A lot of times we miss emergent alarms, such as life-threatening cardiac alarms and fall alarms. Each can cause serious harm to the patient. A decreased patient satisfaction. Patients develop sensory overload, which makes them kind of not happy with their hospital stay, and their rest is limited. Also, there is a poor nurse job satisfaction. During my research, I came across 5 pertinent studies related to my research proposal topic. A non-experimental study was done in an ICU setting during a 48-hour time period. It helped observe alarm fatigue. The purpose of this study was to observe the intensity and frequency of cardiac alarms and alarm fatigue. The data was collected using methods such as t-test and a manual counter. During the 48-hour time frame, approximately 2,184 clinical alarms were counted during a 48-hour time period. Of the 2,184 sounding alarms, 1,394 of them were proved to be false. So that's quite significant. For my second literature review, the study was a 43-day time span, and it was used to display alarm fatigue as well. The study compared significant alarms versus non-significant alarms. During this observed time, nearly 40% of the alarms were due to insufficient premature ventricular contraction alarms. Without these non-life-threatening alarms sounding, the unit would have been a much quieter place. As a result of the study, the default settings of the pair, PVC, multi-farm, and run PVC alarms were permanently switched to the off. With this being said, other units should take a look at this option to help decrease noise and alarm fatigue throughout their units. The third study that I found was a quantitative study performed in 2015. The differences between default alarm limits and patient-specific alarm limits were examined. The study took place in a cardiac care unit over a 2-week time period. Although the number of these sounding alarms proved to be significantly large, the study was found to be less sufficient due to the small sample size. A 2-week time frame was not really long enough to get an accurate reading. If a longer study would have been performed, consistency in these sounding alarms may have been found. And that is the conclusion of the third literature review. The fourth literature review is a quantitative study as well. Setting patient-specific alarms and nurse education was analyzed. For 10 weeks, the nurses were expected to leave the alarms on the default setting for each of their patients. During this time frame, the nurses' attitudes and responsiveness were evaluated. During the second 10-week time frame, the nurses were asked to change the alarm limits specifically to each of their patients. The attitudes and responsiveness to alarms were then again reevaluated. The results varied from each nurse. Many of the nurses stated that they needed more education on changing alarm limits. With this being said, there was a large decrease in alarms per patient per day. However, if the nurses would have been more comfortable with changing the alarm limits, the numbers would have been lower. And for my fifth and last literature review, it is also a quantitative research study that shows which alarms sound frequently, which ones are critical, and which ones are of less importance. During a 31-day time period, a total of 12,671 arrhythmia alarms sounded. According to the study, nearly 89% of them were false. As a result of the 5 studies, false alarms happened quite often. And my PICO statement. I would like to conduct a research to determine if setting patient-specific alarm limits compared to unit-specific alarm limits would decrease nurse alarm fatigue, thus improving patient outcomes by decreasing the incidence of cardiac alarm frequency. The population would be critically ill patients. The intervention would be to set patient-specific alarm limits. Another example would be, just as we do here at Good Samaritan ICU, we would change alarm tones for each type of alarm, so that way we would know why each things are sounding and if they're more critical. And then the comparison will be alarms set the same for each and every patient in the ICU compared to ICU nurses, and then the comparison will be alarms set the same for each and every patient in the ICU. With this being said, ICU nurses become complacent with alarms. Thought the computer wanted to sleep on me there. The outcome would be favorable patient outcomes, heightened awareness, and recognizing early signs and symptoms of patient deterioration. Theoretical framework. The environmental theory was developed by the founder of modern nursing, as we all know, Florence Nightingale. The theory suggests certain aspects of an environment can bring about sickness and unfavorable outcomes. With numerous false alarms sounding in the critical care setting, an extremely noisy environment exists. The nurses and patients are affected by these conditions. With many false alarms, the nurse can become insensitive to the sounding alarms, creating a lack of observation. If proper interventions were taken, such as changing electrode pads, setting patient-specific alarms, and educating staff members, many alarms would not be falsely alarming, and Nightingale's environmental theory would be closer followed. And here is a picture of Florence Nightingale. Design, setting, and sample. The study would include a pre- and post-test design. A pre-test would be used to determine the nurse's pre-course knowledge regarding cardiac alarms and electrode placement. A post-test will be administered to determine the nurse's knowledge after the course was taken. The setting would be a 30-bed intensive care unit in a small rural area located in Indiana, just like we have here. That's where I got the idea. Education, pre- and post-test would be used to gather data. The critical care nurses would be required to attend a cardiac telemetry course. At the beginning of the course, each nurse would be asked to complete a pre-test to determine his or her baseline knowledge of cardiac monitor, rhythm, accuracy, and lead placement. The scores would be measured before the course. Over a 3-month time period prior to the course, the nurse's pre-course knowledge and abilities would be assessed. For 3 months after completing the course, the nurse's knowledge regarding the care of cardiac monitors would also be reviewed. The nurses would be required to take a post-test consisting of the same 6 questions as the pre-test. The scores would be measured after the course. A benchmark would be set requiring all nurses to score a 90 or above on the post-test. As a result, with cardiac monitor education, a decrease in the incidence of non-essential cardiac alarms would be found. Data collection and analysis. The pre- and post-test would consist of the same 6 questions, which can be found in Appendix A on the next slide. T-tests of significance would compare the results. The nurse's pre- and post-test scores would be compared with a dependent t-test. Since there would be numerous patients, an independent t-test would be used to determine if the incidence of unnecessary alarms decreases. A graph would be drawn up to display the results. While no valid or reliable tool is used, quantitative data would be used. As a result, a decrease in the incidence of non-essential alarms would be noted, thus decreasing alarm fatigue. And then this next slide here is Appendix A, and this is a sample of the pre- and post-test that will be used in my research proposal. Number 1 states, as an ICU nurse, are you allowed to set patient-specific alarm limits without a physician's order? Number 2 states, what 3 areas can you change alarm limit settings? In what 3 areas can you change alarm limit settings? 3, when should you change alarm limits to fit a specific patient? For example, if you had a patient with COPD, you would set their O2 limit lower because we expect them to have a lower oxygen saturation to help them breathe easier. 4, how many leads should be placed on each patient for cardiac telemetry? 5, where should each lead be placed? 6, what are the reasons to change patient electrodes? And the conclusion. Alarm fatigue in nurses can lead to poor patient outcomes and safety awareness. In high monitored areas such as the ICU, hundreds of alarms sound per day. With a tremendous amount of alarms sounding, it is easy for the nurses to become complacent. As a result, alarms are missed. There is a delay in treatment for critically ill patients, increased falls, poor patient satisfaction, and poor nurse job satisfaction. If the frequency of insignificant alarms were minimized, alarm fatigue would be at a minimum. Critical alarms would be acknowledged sooner and patient falls would be at a minimum. The research proposal statement above is important to help improve these patient outcomes. In short, changing alarm limits for each patient and changing electropads may decrease alarm fatigue, creating optimal patient outcomes. Then the last 2 slides here are the references that I used throughout my capstone project. And that is it. Are there any questions?
Very good.
We are done.